to our biomarker lightning round session on this last morning here in Toronto. I'm really excited and pleased to share with you that all of our presenters today are trainees at different levels, and they're going to be sharing with us some really exciting news about the work that they've been doing. We're going to be doing, each talk is relatively quick, 4 minutes, and at the very end, we will be having the group panel discussion and question and answer as usual for the rest of the program. So our first speaker is going to be Wu Jiayi, who is coming to us from Fudan University in China, talking about accelerometers.
Thank you for your kind introduction. Good morning. I'm Wu Jiayi, a medical student from Fudan University, China. Today, I'm going to share with you our research entitled Accelerometer Measured Physical Activity, Sedentary Behavior, and Incident Neuropsychiatric Disease. Photo, video, audio recordings are prohibited in this presentation. Physical activity and sedentary behavior has recently emerged as a critical determinant for brain health. A large number of studies have been conducted on the association between physical activity, sedentary behavior, and the risks of neuropsychiatric disease in the last decade. However, most of them employed self-reported data, which due to recall bias may exhibit inconsistencies compared to objective measures. Therefore, we aimed to address the following questions. First, explore the relationship between physical activity, sedentary behavior, and neuropsychiatric disease. Second, investigate the underlying inflammatory, metabolic, and protein mechanisms. The present study employed data from UK Biobank, objectively quantifying physical activity through energy expenditure and time allocation. Our study included 5 physical activity measures and 5 neuropsychiatric diseases. Cox analysis shows a strong association between physical activity, sedentary behavior, and 5 diseases. Higher physical activity, energy expenditure, moderate to vigorous intensity physical activity, energy expenditure, and the proportion of time spent on MVPA were associated with lower risks of 5 diseases, and sedentary time was a risk factor. The nonlinear association was also evaluated. The relationship between physical activity and the risks of neuropsychiatric disease were L-shaped. And for the sedentary behavior time allocation, the association presented a reversed L-shaped with a significant elevated risk of dementia after the NADL at the proportion of 27%. Physical activity and sedentary behavior were also associated with brain functions. Higher physical activity, energy expenditure, and time allocation were associated with better performers. And conversely, less sedentary behavior was associated with them. Meanwhile, the cortical signals findings indicated that higher levels of energy expenditure and time allocation were associated with reduced lateral occipital cortex and right cuneus. Key subcortical structures included accumbens. To further investigate the neuropsychiatric mechanisms, we demonstrate 224 associations of physical measures with inflammatory markers, 982 with metabolic markers, and 2,582 associations with protein markers remain significant. Structural equation models suggested that inflammatory and metabolic markers may serve as an important mediator in the association. Finally, I'd like to thank Professor Yu and our cognitive group. Thank you for attention. Thanks.
Thank you so much. Our next speaker is actually a virtual speaker. We should be joined here by Hamza Anan from Saudi Arabia.
Hi everyone, my name is Hamza and I'm an upcoming fifth-year medical student at Al Faisal University. My topic for this presentation is digital voice as an alternative screening tool to the MoCA. What I'll quickly be talking about is mild cognitive impairment, MoCA, acoustic features, RASTA, and then I'll be moving on to the methodology, results and discussion, and future directions of the research. What is mild cognitive impairment? Well, according to the Alzheimer's Association, mild cognitive impairment is an early stage of memory loss or other cognitive ability loss in individuals who maintain the ability to independently perform most activities of daily living. What is the MoCA? Well, the MoCA is a widely used screening tool for detecting cognitive impairment. It's based on a 30-point scale. However, the MoCA has limitations, which include cultural bias, education level sensitivity, limited early detection, and it's not diagnostic, which is why in our research we plan on using acoustic features. An acoustic feature is any acoustic property of a speech sound that may be recorded and analyzed as its fundamental frequency or format structure. It's used in speech recognition, emotion detection, medical diagnostics, among other things. The types of acoustic features include temporal, spectral, prosodic, voice quality features, and spectrotemporal features. In our research, we use spectral features, specifically the RASTA filtering. What is RASTA? Well, RASTA is a signal processing technique used in speech analysis to enhance relevant spectral features while reducing noise and distortions. It filters out slow varying distortions while preserving meaningful speech patterns. It's commonly used in speech recognition and cognitive health assessments to improve signal quality and analysis accuracy. So what makes our research unique? Well, our research focuses on RASTA, filtered spectral features. It uses an open source speech processing tool, OpenSmile, and it analyzes short audio from a picture description recall task. Our demographics included a mean age of 68.7. Around 81.25% of our participants were educated. About 60% of those participants were female, and we had 80 participants which came from the BU ADRC. Each recording was divided into 20 millisecond frames using a 10 millisecond sliding window, and 26 raster-styled filtered auditory spectrum bands were extracted. We had two summary statistics that were applied, which were the mean and up-level time 75. Linear regression was the statistical method that was used to model the relationship between a dependent variable, which in our case was the MoCA total score, and one or more independent variables, which were the acoustic features. The model was adjusted for covarieties such as age, sex, and education to account for any potential confounding factors, and our mean MoCA score was 26.49. Our main findings showed 5 spectral features that had negative associations with the MoCA total score. Band 25 demonstrated the strongest negative relationship, indicating a robust relationship with the MoCA scores. And the feature up-level time 75 performed better in identifying correlations with MoCA. This is a table of the results, which you could find on our poster. And the limitations included a small sample size, limited feature extraction, and potential confounding factors. Our key takeaway is certain spectral features were significantly associated with the MoCA scores, and we believe that voice-based screening could provide a culturally and linguistically agnostic approach to detecting MCI. For our future directions, which we're currently working on, is expanding the abstract to full manuscript, expanding the preliminary results, feature selection with machine learning, stability and reliability testing. Thank you. Do you guys have any questions for me?
Okay, next up in our lightning round is going to be Kaoyi Yang, who's joining us from the Wisconsin ADRC.
Good morning, and thank you for that introduction. My name is Kaoli Yang, and I'm from the University of Wisconsin-Madison in the USA. I have nothing to disclose. Amyloid and phosphorylated tau are known to colocalize within synapses in the entorhinal cortex and the hippocampus, and synaptic loss is a top correlate of cognitive decline. Hyperphosphorylated tau is believed to disrupt axonal transport of synaptic vesicles. And in the blood, plasma p-tau217 robustly marks Alzheimer's disease pathology, and synaptic density as assessed by C11 UCBJ PET tracks cognitive performance. Given that plasma p-tau217 is reflective of amyloid and tau brain aggregates, here we focus on p-tau217 to explore its association with synaptic density. We hypothesize that greater Alzheimer's disease pathology, here marked by higher plasma p-tau217 levels, will associate with lower synaptic density in brain regions that are vulnerable to pathology accumulation. 50 participants were recruited from the Wisconsin Registry for Alzheimer's Prevention, and p-tau was quantified from plasma using the ALZpath p-tau217 assay on Quanterix. Synaptic density distribution volume ratio was quantified from C11 UCBJ PET using Logan graphical analysis with a whole cerebellar reference region, and 6 regions of interest were identified using free-surfer T1-weighted MRI parcellation. We determined cognitive status via a comprehensive neuropsychological battery that was reviewed by a consensus diagnostic panel, and participants were identified as being cognitively unimpaired, mild cognitive impairment, or having Alzheimer's disease dementia. And multiple regression were used to assess the relationship between synaptic density and plasma p-tau217. We used Cohen's F-squared to assess the strength of those relationships, and for your reference, there is a base model up. Participants in this cohort were mostly female, mostly white. 38 were cognitively unimpaired, 11 had MCI, and 1 had dementia. Given the lower cases of MCI and dementia for statistical analyses, we group these two together into an impaired group. For the hippocampus, the model showed a good proportion of the variance was explained, and it was a significant model. And we saw in the hippocampus that cognitive impairment was associated with higher p-tau217. So lower cognitive impairment being associated with lower synaptic density and higher p-tau is as expected for this directional relationship. In the entorhinal cortex, we saw a different relationship between plasma p-tau and synaptic density, but overall the model explained a modest variance, a modest proportion of the variance, and it was also a statistically significant model. Here we saw that plasma p-tau217 was associated with synaptic density in a positive direction. However, the relationship with cognitive impairment remains that lower cognitive impairment was associated with lower synaptic density. In conclusion, cognitive impairment was associated with lower synaptic density in the hippocampus. Higher levels of plasma p-tau217 was associated with synaptic density in the entorhinal cortex in the positive direction. And also in the entorhinal cortex, we saw that cognitive impairment was associated with lower synaptic density. So the unexpected directional relationship in the entorhinal cortex we think may be due to hyperexcitability. However, we do need to conduct more research to further elucidate this relationship. I would like to acknowledge my incredible mentor, Barb, as well as several wonderful collaborators whose contributions made this research possible. Also, thank you to AAIC for the conference fellowship that allowed me to be here today to present. Thank you.
All right, so our next speaker is also a medical student, Justin Ong, who is joining us from the Nanyang Technological University in Singapore.
Thank you. All right. Good morning, everybody. Thanks so much for coming. I'm Justin. I'm a medical student from the Lee Kong Chian School of Medicine, NTU, Singapore. And today, I'll be presenting my abstract on enlarged perivascular spaces, or EPVS, as early indicators of Alzheimer's pathology and cognitive impairment, using data from the BioSys study conducted at the Dementia Research Centre, Singapore. Yeah, so EPVS is part of a group of diseases known as cerebral small vessel disease, which also includes white matter hyperintensities, lacunes, and microbleeds. Among them, EPVS still remains relatively understudied. Given its role in impaired perivascular clearance and lymphatic dysfunction, we wanted to explore whether EPVS could serve as an early indicator of Alzheimer's pathology and cognitive decline, and see how it compares to the other CSVD markers in this context. So our data is taken from this study, the Biomarkers and Cognition Study Singapore, or BioSys. This is a large multimodal cohort study in Singapore where participants undergo neuroimaging, blood biomarker analysis, cognitive testing, lifestyle and behavioral profiling, retinal imaging, and microbiome assessments. Based on this dataset, we formulated two key aims. Firstly, to examine whether basal ganglia EPVS is associated with Alzheimer's pathology using blood-based biomarkers, and to compare its predictive strength with other CSVD markers. Our second aim is to assess how basal ganglia EPVS relates to domain-specific cognitive performance. So we analyzed cross-sectional data from 979 participants, grouping them into cognitively normal, subjective cognitive decline, and mild cognitive impairment groups. Cognitive scores, blood biomarkers, and CSVD MRI markers were extracted. And CSVD markers were rated using the STRIVE-2 criteria and classified into high versus low burden using style scoring. For statistical analysis, demographic data was analyzed using ANOVA and chi-square test. For biomarker analysis, we performed Spearman correlations between CSVD markers and Alzheimer's-related blood biomarkers, and to take it one step further, logistic regression in the MCI subgroup to identify predictors of pathology. For the cognition study, we conducted logistic regressions between EPVS burden and neuropsychological test performance. Here are key findings from the biomarker analysis. EPVS burden positively correlated with neurofilament light chain, glial fibrillary acidic protein, and p-tau181, and negatively with the amyloid beta 42:40 ratio. Interestingly, in participants with MCI, EPVS emerged as the strongest CSVD predictor of Alzheimer's pathology, outperforming other markers like white matter hyperintensities, or WMH, lacunes, and microbleeds, which were not retained in the final regression model. In terms of cognitive performance, higher EPVS burden was significantly associated with poor scores on the block design test, which assess visual spatial function and executive functioning. No other significant associations were found in other cognitive domains. In summary, our findings suggest that EPVS may hold prognostic value as an early marker of Alzheimer's pathology, potentially reflecting early vascular and lymphatic dysfunction. It may also have domain-specific cognitive impact, particularly in visual-spatial and executive functioning. Clinically, EPVS is a promising cost-effective imaging biomarker. Since MRIs are routinely performed in the workup of cognitive decline, incorporating EPVS ratings into standard reporting could help with early detection, monitoring, and intervention for patients. And finally, combining EPVS with something like WMH, which has a much stronger literature base, may further enhance diagnostic efficiency, especially in settings with limited access to expensive and time-consuming resources. And that concludes my presentation. Thank you so much for your attention.
Okay, and our last speaker in this session is going to be Patricia Chatterjee, coming to us from Australia.
Thanks, Stanley. Good morning, everyone. I'm Pratishtha, and today I'm going to talk to you about some preliminary data that I validated in one cohort, one independent cohort, and I want to validate it in another independent cohort. So if anyone has a suitable cohort, please get in touch, and I'd really be keen to collaborate. So the amyloid and tau biomarkers have really shifted the diagnosis of Alzheimer's disease from clinical diagnosis only to the integration of these biomarkers. And we know that the sequence of events is amyloid pathology followed by tau pathology, and this sequence has been associated with cognitive impairment. So if we have clinical diagnosis of Alzheimer's disease along with the amyloid and tau pathology biomarkers, of course, it's Alzheimer's dementia. But what about if we have clinical diagnosis of Alzheimer's disease with, say, amyloid pathology positive, but tau pathology negative? So you have dementia, but your tau pathology negative still. What dementia are we talking about? So we've still got to figure that out. So our biomarker framework that we have right now, it exposes this deviation. And there are about 15 to 20% of individuals who actually fall under this category within the cohorts we've investigated. And this poses a significant clinical challenge, I think. So we wanted to address this problem by first starting with APP and its derivative products. So that's A beta 40 and 42. But for the purpose of this presentation, I'll just talk about about APP. And we investigated it in the cerebrospinal fluid. Now, APP, of course, is a synaptic protein. And we know that low APP conceivably would result in impaired brain function. Now, APP knockout mice have shown neuronal loss, impaired cognitive function, as well as impaired vascular regulation. And within humans, when CSF APP was investigated in Alzheimer's disease, we previously investigated it without accounting for the amyloid and tau pathology. And when it was accounted for, it wasn't really stratified by tau pathology positive and negative status. So we looked at that, and what we found was that if you look at within each clinical diagnosis, that is cognitively unimpaired individuals or mild cognitively impaired individuals or dementia, you will see that in the T negative groups within each clinical diagnosis, APP in the CSF is much lower when compared to the T positive counterpart. And what you also see, so we first looked at this in the ADNI cohort. We measured CSF APP we didn't measure, but this was available. It was measured by an ELISA. And then in the Amsterdam cohort, Amsterdam dementia cohort, we could validate these observations. And this was measured with TMT-MS. Now, what you can also see is that with clinical progression within the T minus, you'll see APP is going down. And again, within the T positives, you see APP decreasing. So you see this in both the cohorts. So this is just a schematic of the results that I just showed you, where you can see that within the T negatives, that's marked in blue with disease progression, you see a decrease in APP. And also, while in the T positives, APP is higher in the CSF, but it does decrease with disease progression. So we also observed a higher frequency of dementia cases in individuals who had low CSF APP, and also they had lower cognitive and functional performance. So we plotted the individuals as in their the CSF versus CSF p-tau versus CSF APP levels, and we stratified them based on quartiles, based on the CSF p-tau established cutoff, measured by the ALSBio 3, and the CSF APP beta or APP levels. We stratified them based on the Udin's index threshold that we got based on a T negative versus T positive pathology. And what you can see is that quartile 2, which has low CSF APP, has a higher frequency of dementia cases when compared to quartile 1, which has high CSF APP. And again, you see in quartile 4, which has low CSF APP, when compared to quartile 3, has a higher frequency of dementia cases. And you'll see that the highest frequency of dementia cases are in those individuals who have high CSF p-tau, which is not a surprise, of course, but also in those who have low CSF APP. Now, again, when you look at the CDR sum of boxes, you again see in quartile 2, you have a higher CDR sum of boxes, that is more cognitive and functional impairment when compared to quartile 1, and the same you see with quartile 4 compared to quartile 3, and you see a similar thing with MMSE as well. So just to summarize, we observed a higher prevalence of AD-like dementia in APP positive or p-tau positive individuals, but we saw the highest prevalence of dementia in those with both markers as positive. And this reveals a unique biological profile of tau pathology positive status in clinically diagnosed Alzheimer's-like dementia. Now, this findings show disruptions in APP processing or production may contribute to disease progression, given that we know that APP influences neuronal plasticity, memory, and synaptogenesis. So I'll ask you again, could low APP signal low AD-like dementia? And I think we still need to investigate this further. So if you do have data that would be suitable for this analysis, please get in touch with me. So I'd just like to acknowledge all my co-authors and funding agencies. Thank you.
Okay, so I want to thank all of our speakers for these really interesting and novel presentations, and we are open for questions. Please come to the microphones and introduce yourselves. We're also looking for questions online, so I'm going to be refreshing that as we go. So I guess just going down the line, if we start with Wu Jiayi, I thought it was really impressive that you were able to harness UK Biobank to do this large study working in China. And I thought that first I just wanted to compliment you on that work and state for everyone here how much this really helps demonstrate the value of open science and data sharing and the cross collaborations and dementia work that we're seeing here at the meeting. So I wanted to thank you for that. My question for you is, when you're looking at a big established data set like that, how do you start to think about what is cause versus effect when you're looking at your data? And what are your thoughts on how you would go to see, within your findings, was the physical activity driving the neuropsychiatric profile or vice versa? So what would be the next steps you would do if you could design the next experiment? It'll automatically adjust for you, yeah.
Maybe I will find a question. Maybe when I started to looking the big data, I will find what I am interested, and I try to find what data is available for my questions. I think UK Biobank is a very large scaled biobank for most scientifics, and included various data, including imaging and accelerometer physical activity, and so many biological markers for me to start such big research. And finally, I want to thank UK Biobank for the support for our research. And the future directions, maybe I will try some animal experiments to figure out, such as IVJV protein play what role in the mediator of the association of physical activity, sedentary behavior, and neuropsychiatric disease.
And there is a related question online for follow-up for you, says, did I understand correctly that sedentary behavior was associated with a thicker cortex?
No, it depends. In my present.
So it in part of the presentation, it looked like there was a paradoxical finding that people that were sedentary, that didn't exercise, actually had larger brain structures. But maybe there was a misunderstanding. So did you find the exercise was associated with small brain structures?
Actually, it depends. Several you can find specific regions are smaller and some are larger. And I still try to find out why they works, how they works, and try to figure out deeply. Yeah.
Okay. All right, thank you. So, yes, microphone number 1.
Zetterberg, University of Gothenburg. I have a question for you, Pratishta. I thought it was exciting that you looked into the soluble APP fragments in CSF, and since they're relatively easy to measure, so I think we should do exactly like you did and look at what they might mean. My question to you is, do you think the SAPP data give you something else than what you can gain from A beta 40?
Thank you, Henrik, for the question. We did look at A beta 40 as well, and we did look at A beta 42 as well. So A beta 40 basically gave us the same results that we saw with APP. A beta 42, on the other hand, gave us very different results. Yeah. Does that answer your question? Or was there anything else?
Yes, it does, but I also think that it's good that we look at all these pieces.
Yes.
And they are relatively easy to measure also.
Yes.
So we have become so soluble tau focused lately, but we can also continue to look at the beta and APP part, I think.
Absolutely.
So thank you for that work.
Thank you.
All right, we're going to go to microphone 5 next.
So, hello, I am Ana Beatriz Solana from G Healthcare, and I have a question for Hamza. I hope that I'm pronouncing it correctly. So I have 2 questions, actually. So why did you select the spectral features and not the others, or if you have analyzed the other and you have decided that for some reason? And the second one is if those or some of the features are going to have an impact for different languages. This is out of curiosity because I don't know anything about the topic. Thank you.
Those are great questions. So the reason why we use the spectral features and not the other ones is because the spectral features aren't that well studied compared to the others. So our main line is focusing on the spectrals at the moment. However, we will be conducting more research and focusing on the others. And so another cool fact about this research in general is the reason why we're using voice is so we could use other languages and try to detect mild cognitive impairment through other languages.
Thank you.
Okay,
you.
and back to microphone number 1.
Thank you. My question to the last speaker, that was fascinating. Like you said, we see these patients in the clinic quite a bit. Have you done any longitudinal analysis?
Yeah, I'm very keen to do longitudinal analysis.
Yeah.
We've just about, it's been a few months since we've started this, so I'm very keen, but it's just about getting access to cohorts. So yes, if I get access to the data, I'd be very keen to look at it.
And we can collaborate because I have some.
Excellent,
So, yeah,
excellent.
Yeah. I'm Tina Chabrashvili from SUNY Upstate New York.
Okay, I'll get in touch with you soon
fantastic.
after. Thank you so much.
Okay, and microphone number 3.
Hi, Pratishta. It's Ashwini from UCL. Nice to see you again. And hi, Henry. I wondered if with the soluble APP, because there will have been the trials of people who had amyloid-lowering therapies, whether in those people who have been deeply phenotyped post receipt of those therapies in the trials, you might be able to approach the trialists for CSF samples to look at the profile of response to those treatments over time.
Yeah.
Because it could be that it might show you something different about how their centiloids go down as opposed to the time frame of when the soluble APPs go down. And or A beta 40.
That's a great idea.
I didn't know whether it's already been done. So
No,
that's what
so of course these data are very old data that I've extracted from ADNI and from ADC as well. This was before the amyloid therapies were definitely, approved. But yeah, now that we do have these therapies approved and people will be undergoing this, I think that's a great idea to look at that as well.
Yeah, Henrik, did you know if it's already been done?
I don't think anyone has been looking at APP. I think APP is the old guy who no one's really interested in.
Sometimes oldies are goodies.
Yeah, yeah, absolutely.
I could just comment, I see in the audience, Ville Leinonen from Kuopio. There, he waves. He has very nice SAPP data on people with normal pressure hydrocephalus who have undergone brain biopsy, and he has A and T categories by brain
wow.
biopsy. So you can collaborate.
Yes, I will. Thank you so much, Henrik.
Okay, so I have a question for Kao-Lee. I thought it was really interesting that you had these opposite findings between hippocampus and entorhinal cortex in terms of synaptic density and the relationship to p-tau217. And I wonder if you could just expand a little bit more about, you mentioned hyperexcitability, but sort of what are your thoughts about that, other mechanisms, and kind of what plans would you have to do further validation or exploration?
Thanks for the question, Tammy. So I would just like to clarify that I didn't technically find opposite directional relationships between the hippocampus and the entorhinal cortex because the association between plasma p-tau217 and synaptic density in the hippocampus was not technically significant.
Okay.
So, but with that being said, it is in the same direction. So I do think that there is something going on where perhaps the plasma p-tau217 is signaling the start of a toxic accumulation cascade. At least this is what I've gleaned from the animal literature and the postmortem studies. So I think in vivo studies, it would be useful to expand on our cohort and have well-characterized clinical groups and then examine these features across the group. So this is a relatively small sample that I explored this relationship in. We had 50 people with all the data. So I think in the future it would be important to look at it in a larger group as well as longitudinally.
Okay, thank you. Oh, number 5.
Yeah, so I actually have a follow-up question. Could it be related of different staging of the disease, or all the samples that you used were kind of classified for the same staging?
Sorry, I just want to make sure I understand your question. Are you asking if it could be a marker of different disease stages?
Yeah, exactly.
I think so. Right now, the data is too small to say that. I think it could be signaling something that's happening perhaps before cognitive decline and before pathology reaches a critical threshold to show cognitive decline.
Yeah.
But that's to be determined.
Sure.
Okay, and Justin. So I have to say, you know, when we look at these perivascular spaces and the measurements of them, you know, at the beginning of your talk, you show examples of the, you know, visually on the T-tooth of the different degrees of it. But I have to say, as a neuroradiologist in real life, most of the patients I see are going to be in that category 1-2, not that full breadth of the measurements. And I'm wondering, did you look at the distribution of your data? Could you comment for us on just a little bit more about how, you know, is it a normal distribution about the middle, or exactly what does that look like for you guys?
Yeah, that's a great question. Actually, rating the PVS in the MRI was quite a difficult experience for us because there's also quite a bit of inter-rater discrepancies when it comes to PVS compared to something like white matter hyperintensities, where it's usually quite standard when we do double-blind ratings. In terms of the distribution, as you said, most of it does fall under 1 or 2, and maybe about 10 to 25% will fall in our cohort, fell under like a 3 or 0. That's why it's probably that's why I in the clinical implication section, I thought it would be great if we potential to combine it with WMH, something that's a little bit more reliable, better studied. And then using that, you can create a little bit more holistic picture. And maybe a future research direction will also probably to maybe make the difference between the stages a little bit smaller, maybe like 5 to 10, 10 to 15, 15 to 20. With that, it can try to make the differences a little bit bigger when it comes to the PBS ratings.
Yeah. Okay, thank you.
Thank you.
All right. Checking online again. Oh,
Yeah.
oh okay, good. We have a few last questions. Number 5 again. Go ahead.
Yeah, well, I would just have like a follow-up comment for that. Could this be improved by kind of an automatic characterization of the PBS burden instead of having a manual that you always have this inter-rater variability? Have you thought about like trying that something more automatic?
Yeah, that's a really great question actually. Our center has been trying to work on some automated pipelines for grading PBS on a large scale, but it's a lot of work and a lot of technicality, which is kind of is out of my scope. But there are people in the center trying to work on it. But I think that's a really good idea, and maybe with that we can also, instead of just counting the number of PBS for the grading, we can start looking at PBS volume itself, and with that we have like a more continuous variable, and the data can be analyzed in different ways. But thank you so much. That's a really great idea.
Okay, number 3.
Hello, thank you all for very amazing presentations on novel biomarkers. I have a particular question for Patricia. Given that APP processing is through base 1 and gamma secretase sequential cleavage, would you say that it would be of interest to also look at different A-beta biomarkers, especially in terms of the A-beta clearances, and looking into how base 1 potentially is being enzymatically functional, as well as gamma secretase?
Yes, so base has definitely been investigated a lot. I think in terms of this study and these findings particularly, so when we adjusted for amyloid, we did not see any difference, right? So base is towards A beta 42, 40 of course as well. So I think this is more towards the non-Alzheimer's side of things. So while, yeah, it would definitely be interesting to see base, but I would think that base would probably be more relevant to the Alzheimer's part of biomarkers. Here I'm trying to look at this population, which is really not being studied. It's been a little bit underexplored. Probably base would be, I don't know, it's hard to say because we have looked at people, regardless of their amyloid status, tau negative versus tau positive, and also within all amyloid positive individuals, but tau negative and tau positive. So we stratified them as well in that way, and we still see this difference in APP. So it's more to do with tau, I think, than the amyloid side of things for this non-Alzheimer's dementia. But yeah, definitely, I will look at it, and I'm sure some data should be available. So thank you for that. Yeah.
Thank you. Appreciate it.
Okay, last question, also microphone number 3.
Thanks. This is a question regarding the EPVS. I'm sorry if I missed it in the presentation, but I wondered if you looked at whether your findings were being driven predominantly by people who have other features of cerebral amyloid angiopathy, such as microbleeds?
Oh, yes. Yeah, actually, also it's saying whether or not the other cerebral small vessel disease markers has an impact on PBS. Is that what you're asking?
Well, predominantly microbleeds in the cortex, which are probably more predictive of CAA as opposed to small vessel disease as such.
I see.
Yeah.
Actually, in our study, we didn't manage to run an analysis on that, but that's a really great question. That's a really great idea.
It'd be nice to count the microbleeds and maybe categorize people as, just a crude way to see if a group was driving this association.
Yeah, maybe I can get your email after this, then if I run any data, I can
Just a
see if there's
suggestion. I'm a
anything.
clinician, not an imaging expert, but certainly feel free to connect.
Great, thank you so much.
All right, so I just want to say again, thank you to all of these speakers. They are all trainees at different levels, and it's so exciting to hear their clear presentations and great job answering the questions on the panel. We're just like, you guys are the future of the society, and we're really proud of everything that you've been doing. So congratulations and thank you.